How to assess a patient with epistaxis. First things first, if you have a patient with epistaxis, what do? You have to do airway assessment. And then you have to check for cardiovascular stability. Okay? So you have to assess the airway because you want to make sure that the airway is not compromised. And you want to check for cardiovascular stability. And in severe epistaxis, you have to do airway intervention, fluid resuscitation, and emergent otolaryngologic consultation. So airway and cardiovascular stability are critical. Don't just be moved by the fact that the patient is losing blood, but ask yourself, is the patient's airway compromised? That is one thing you want to focus on and make sure you've dealt with. Okay? Now, what to focus on when taking a history of a patient with epistaxis? Because remember that the objective was talking about it, that you need to know how to take a patient's history in a patient with bruising. So whether it is von Willebrand, whether it's hemophilia, whether it is, any condition, you must also focus on history. So what are the historical facts after you've stabilized the patient's airway and circulation that you ask about? What is the onset of the issue or the epistaxis? What is the cause? What is the duration? So if you're preparing for your NACOSCI with MedCognito, you realize that we will always be hitting on OCD, onset, cause, duration. So the timing, the frequency, and the severity of the epistaxis should be assessed. Okay? Is this a recurrent episode or it is an isolated case? Has there been any history of ENT tumors? And we've learned which people it is common in. And we've learned that if there's a nasal tumor, there will be facial pain and unilateral nasal blockage, right? Is there a history of coagulation disorders? Is there a family history of coagulation disorders? You will also want to ask, has the patient had any facial trauma as well? Okay. And the possible presence of chronic medical problems that can be exacerbated by blood loss, such as coronary artery disease, such as chronic obstructive pulmonary disease, and symptoms that may be related, like does the patient have any chest pain, any shortness of breath, any lightheadedness? Okay. And has there been any recent surgery? And what is the patient's medication history? And has there been any chronic conditions like cirrhosis, like HIV? Okay. And does the patient use cocaine? You want to go into the social history as well and find out, does the patient use cocaine as well? Because that is what you want to, inquire about. These are critical things you want to focus on so far as the patient's history is concerned. Okay. Now, what about the labs? What about the labs in epistaxis? What about the labs? Is it every patient with epistaxis that you request PT with INR? No. Don't request PT and INR routinely in patients with epistaxis. Please don't do that. So whether it's in your CDM or in your MCQs, don't do that. The only time you want to request for PT and INR in a patient with epistaxis is if you are told that the patient is on either warfarin, low molecular weight heparin, unfractionated heparin, or any of the DOACs like rivaroxaban, apixaban, and dabigatran. That is when you want to request for PT and INR. So don't be, answer triggered to the extent that as soon as you see PT and INR, hey, no. Please remember that when you came to MedCognito, Dr. Bruni told you the conditions under which you request for PT and INR as part of your blood work for patients with epistaxis is if the patient is on anticoagulants. Okay. Now, you also want to request for, of course, hematocrit and type and cross match if there is profuse and massive bleeding. Most of the time, a lot of the patients who come to the ER with epistaxis, which is self-limiting, you may not even request any labs for them at all, right? But if it becomes necessary, first start with CBC, and of course, part of the CBC will be their hematocrit and grouping and cross-matching. You will do PT and INR if the patient is on anticoagulation. While you are doing this, don't forget that you set 2 large bore IV cannulae because the patient's hemodynamic status can be compromised, right? It can be compromised. So you want to pay attention to that as well. Now, what is the initial management plan of a patient with epistaxis? First, if it's a simple anterior nasal bleed, the patient should sit, blow the nose so that the clots will come out. Then you spray the oxymetazoline. One doctor said that another name for oxymetazoline is Octravine. That's the trade name in Canada, right? And the patient should pinch the ally, that is the nose, tightly against the septum, okay, and hold it continually for 10 minutes. Now, remember that we did a question on blood pressure control. You only reduce the blood pressure in the patient with epistaxis if the patient is in a hypertensive emergency. That's the only time that you reduce the blood pressure in the patient. If the blood pressure in the patient is normal, don't touch the blood pressure management. It's only when the patient is in a hypertensive emergency, severe hypertension with maybe some papillary edema, severe hypertension with renal compromise, severe hypertension with, chest pain. That is when you want to consider managing the blood pressure alongside epistaxis. So don't be in a hurry to just drop people's blood pressure like that. Dr. Michael, please ask your question.
Please, thank you so much, Dr. Bonnet, for the point. If I get you right, so maybe if the patient is presenting with a high blood pressure and not in having a hypertensive emergency as over
Don't touch it.
Okay.
Don't touch it. Yeah.
Okay.
Don't touch it.
Thank you.
You can easily be tricked.